right, wonderful. Well, thank you so much for the opportunity to talk with you here today. This is a this is a dire time for health policy, and I'm so glad that we've been able to convene today and to learn so much from each other. It's the change on all fronts is so rapid that an opportunity to hear from experts across a range of these different topics is really invaluable. I've learned a ton today. Um, so my goal for today is to help us think not only about actions taken by the federal administration in the past year that are directly focused on healthcare and the quality of healthcare available to people in marginalized groups, but also to broaden our idea about what we think of as laws that are relevant for this purpose. So kind of looking across a range of laws that affect the general population, laws that affect all of our access to resources and stability, the public health environment writ large, and then narrowing it down into laws that are affecting healthcare, and then finally laws that are affecting healthcare for marginalized populations. So I'm going to start with a series of slides that I like to use with my health law classes to try to get students thinking about the stories we tell each other and the stories we tell kind of politically about what is driving illness and death, and in the back of our minds, what's driving health disparities. And the way that you see this problem is really going to drive your focus in figuring out if your effort is to make America healthy again. We need to figure out what level of intervention we are looking to. So there's a famous series of studies that specify the causes of death in the United States over some period of time. So one of these is this very famous paper from the year 2000 with Mukta. There's also been updated papers since then. And the goal of these analyses is to very specifically set out the biological causes of death in the United States. So we've got heart disease, cancer, COVID, injuries, stroke, COPD, Alzheimer's, suicide. These are kind of very specific mechanisms that explain some proportion of the deaths that we have in the US. And generally our top 10 list is pretty stable over time. So this is one way to think about the causes of death. And if this is your lens for how you're going to tackle health and health equity, the answer to this problem is, well, we need more doctors. We need more to treat our heart diseases, to treat our cancer. We need more and better healthcare. We need more preventive healthcare. We need to get these people to the doctor so that we can catch things sooner while they're treatable, while they're reversible. So that's one way to think about this problem. Another more kind of recent, another more recent analysis. Okay, so the Mukta paper looks at the total numbers of death from different causes, but then it takes another step, looking beyond kind of the biological explanations for death. It computes a second analysis looking at the behavioral causes of death. So for all of those cases of heart disease, or cancer, or diabetes, how much of the explanatory story for those deaths can we put on individual behavior? So we have a lot of deaths that are spread across heart disease and cancer and other things. If we look across all of those, how many of those deaths are actually attributed to tobacco smoking, high blood pressure, being overweight? That's a favorite one for these lists. Physical inactivity, high cholesterol, high salt, alcohol use, insufficient use of vegetables, fatty acids. And this is another way to think about the problem. And if we're thinking about it through this lens, which is the lens I think that some of the MAHA kind of framework is using, if we're looking at this as the kind of driving force behind our health and our healthcare and our health inequalities, the answer to this is for people to behave better. And this is, if you're thinking about it from this lens, it's a more comforting story that people are to blame for their own health consequences, that people are engaging in voluntary behaviors, and that in some ways, their health outcomes are a little bit of a morality story. or a sign of behavioral virtue, I think was what one of the previous slides by an earlier presenter said. So this is another way to think about it. But then the third way to think about it, and I suspect I'm preaching to the choir when I get here, is to recognize how these behavioral factors are actually shaped by our social context. And it is this part of the story that really gives us the clue to why marginalized populations have differential health outcomes in the United States, even over and beyond differences in access to high quality healthcare. So when we parse out not only how much is due to these behaviors, but how much of these behaviors can actually be explained by a lack of opportunity or a lack of income or a lack of access to a safe environment, when we start to look at that, we can see that actually many of the deaths that are happening can be traced to a root cause of low education, poverty, low social support, lack of opportunity, the impacts of cumulative racial segregation and income inequality over time. And this is a very famous paper by Sandro Galea that responds to the Mokdad behavioral analysis in the early 2000s. And we can see some of the kind of more updated analyses of causes of death. We'll bring these together. So we see some things here like dietary risks and tobacco use, but we also see the inclusion of things like air pollution, occupational risks, residential radon and lead, malnutrition, violence, unsafe water. So these are these larger structural factors that produce many of our exposures to disease, especially contagious, but also chronic, but also constrain our behavioral options. And so if we're looking at socioeconomic marginalization, and that's what we're looking to when we're looking to health impacts for marginalized populations, we can see that the health inequalities are entirely predictable, and they can be either closed or the gaps between groups can either be closed or expanded based on the structural resources and environments that people have access to. So these health inequalities, they do reflect unequal access to quality healthcare, of course, and there's been plenty of studies on lack of access to care, and also once people get into care, even if you have equivalent access to hospitals and doctors, the type of care people might be getting can be different due to implicit bias or due to lack of access to, for example, private insurance compared to public insurance. But these health inequalities are also expressions of these social fault lines. And I love that phrase. It's from a book by Paul Farmer, kind of thinking about these structural determinants of health. So if we want to connect marginalization to health, it demands that we look beyond healthcare and beyond individual behaviors to those circumstances that shape our exposures and our options. So when I'm thinking about actions of the current administration that we predict will have some kind of impact on the health of marginalized groups, we're looking at actions that not only are affecting access to healthcare, but are affecting a range of other social resources and social determinants. And they can affect those determinants particularly for a marginalized group, but it can also affect those determinants for everybody. And it can be the marginalized groups that are going to be hit the hardest and that are going to feel the most. So I think of this a little bit as, you'll see my image in a few minutes, like a canary in the coal mine model of how general laws or general policies that have an adverse effect on an entire nation, an entire community, can have particularly acute impacts for marginalized people, as well as particularly for people who are multiply marginalized, who have multiple characteristics or identities that are burdened by the way, by a social and economic marginalization. All right, so as we think through I'll spend my next few minutes just thinking about what we've seen thus far in the past year. and how these laws are, or how these actions might be expected to affect health for marginalized populations. So first, we have laws that affect access to quality, effective, and affordable healthcare for everybody, and laws that affect access to other forms of resources, again, for everybody. With both of these groups, I'm looking towards the canary in the coal mine metaphor, that when you are constricting availability of resources for an entire population, it is the people with less political, economic, and social power that are going to feel that pinch the most, that are going to have the hardest time overcoming that restriction. But then third, I will turn to laws that discriminate against or allow discrimination against by private actors for marginalized groups. And these are more targeted. These are laws that are much easier to connect to outcomes among members of these populations that really are the focus of this particular set of actions. And I'm just calling it all laws here. I know it's not all laws. We've got executive orders, we have agencies' actions, we have laws enacted, like the One Big Beautiful Bill Act. So there's a lot that is going under that general label. And this is, I cannot hope to have a comprehensive overview here either, but I do want to give you kind of some flavor of how the accumulation of laws across these three categories is a little bit, like a set of waves that is buffeting the same people again and again. And that is, we can expect that that's going to take a toll. All right, so one set of these laws, and I'm sure you've heard, this is probably repeating some of what you've already heard earlier today, because it's impossible to miss these developments. There are actions taken by the federal government's administration that we can expect will affect everybody's access to quality healthcare. So here's an incomplete list of some of the things happening in Medicaid. As you know, the One Big Beautiful Bill Act has cut $1 trillion out of Medicaid funds over the next 10 years. And this is projected to leave millions of people, double-digit millions of people, without health insurance by the end of this 10-year period. Some of them immediate, and some of them as the 10-year period rolls through. So some of those cuts, some proportion of that, some of those savings are expected to come from the imposition of nationwide Medicaid work requirements, whereas people who, such that people who do not have some kind of exemption, people who aren't disabled or pregnant, people who don't have a medical frailty exemption, which all the states are having to figure out, are required to show, I believe it's a 20-hour per week or an 80-hour per month engagement in something. It need not be paid employment, but volunteering, education, substance use disorder treatment are some of the activities that states have determined would qualify as meeting this hourly requirement. And if they cannot maintain this, they're not going to maintain their access to Medicaid. So nationwide Medicaid work requirements are expected to lead to, and based on our experience with Medicaid work requirements over the previous Trump administration, we can expect that this is going to lead to a contraction, especially of the Medicaid expansion population. Increased redetermination, that means people are going to have to file their re-enrollment paperwork more frequently, which is always an opportunity to lose people in the cracks. Administrative costs are going to be high. These are not cheap activities to administer. So that's also going to eat away at resources available for care, and it's going to be at the expense of states. It is the states that are going to have to build the systems to make this happen. States are also being squeezed in Medicaid by the restrictions on state uses of provider taxes to put that money back into the Medicaid program. So this is going to be a lot of very difficult and unpleasant choices for states that for many states, they were using Medicaid as a way to expand access to healthcare. They were supplementing Medicaid with more state funds in order to cover more populations or health-related social needs, and all of that is getting seriously shrunk down. There's also a new list of Medicaid waiver priorities for experimental and demonstration waivers that are abrogating the uses of those funds for health-related social needs, which states were experimenting with really interesting and creative ways to buy more health in Medicaid by using those funds to assist with housing or nutrition or utilities, things that people were really where that were having an outsized adverse impact on the health of poor and marginalized populations. So all that is also rolling back or changing course under the Trump administration. Beyond Medicaid, of course, we've got a lot of people currently on the Affordable Care Act exchanges that have highly federally subsidized access to health insurance. And these exchanges, as we know from King versus Burwell, they're not going to be sustainable if the subsidies are not continued. Now, currently, those subsidies are augmented by a post-COVID recovery bill. That kind of additional margin of subsidy is set to expire, and it doesn't look like the administration or Congress is really that's one of the sticking points in the shutdown right now. So that is potentially threatening. It's not the elimination of subsidies, but it is the loss of this additional expansion that has been really good for enrollment in health insurance in terms of access. There's also a greater expectation that people will pay out of their own pocket through deductibles, through increased co-insurance or co-pays. And so we can expect to see that reducing the utilization of care at the point of service, especially for low-income populations. And then there's also the kind of administrative processes for operating the ACA and operating the federal exchange. And these are also contracting, set to require kind of more administrative burden for the individuals and eliminating hardship exemptions. So these are some kind of large level universal policies that we can expect are actually going to be more difficult for people in marginalized populations, such as people who are homeless, people who are poor, people with limited English proficiency, people with inconsistent or irregular income, people living in areas without good infrastructure, including good internet infrastructure. It's going to be a lot harder for them to meet these kind of new needs and to cope with the restricted spending by governments in healthcare. There's also kind of a larger bucket of adverse actions or actions that I suspect or that are projected to lead to less quality healthcare or more expensive care. There's an uncertain regulatory environment, and providers are not expecting any shelter or any help from the federal government in avoiding really threatening state restrictions on medical practice, including evidence-based medical practice, especially in reproductive care or gender-affirming care. And that uncertain regulatory environment is leading to a displacement of providers as they try to locate their practices in friendlier jurisdictions. There's an entire leading to kind of expansion of healthcare deserts for particular needs. And it's also affecting the pipeline of providers with the expertise to provide this kind of care. We can see a direct cultivation of uncertainty about some healthcare interventions. We were talking about vaccines earlier. That's a big one. And a disruption of public health infrastructure. The previous speaker, Benjamin Meyer, you did a fantastic job talking about these disruptions, both at the federal and international level, which is going to expose all of us to more health threats and less surveillance, more threats and threats caught at a later stage than what we currently are used to experiencing. Cultivating doubt about healthcare information, especially information from the federal government, is also really risky as we as we are getting no less connected epidemiologically as we move forward. All right, so those are actions that are affecting access to healthcare kind of for the general population. There's also access issues with resources generally. So we can see across the nation, there have been a number of actions taken by the administration that just make money and kind of resources less available. So there's less federal funds for education, there's fewer Pell Grants, there's less student loans and less forgiveness. There's less flexibility for income-based repayment plans and student loan relief. As we know, there's been a multi-sectoral defunding of research and scientific inquiry. There's a lot of economic uncertainty under tariffs. There's been a chilling of some areas of global commerce. There's a lot of disruption to travel and to immigration. And there's been job losses across sectors, especially with the enormous layoffs of governmental employees. Those layoffs have also been concentrated in professional and business services. So this is also kind of teeing up a time of financial instability, of financial scarcity, of household income fears and concerns as we move into whatever our economy is going to look like in this next phase, and where people are feeling the pinch, feeling that lack of opportunity, that is also going to be especially impactful for people who are coming into this moment without a lot of household resources. So people who are already living in poorer jurisdictions, who already have access to lower paying jobs. And then finally, there's a category of laws that either enact or allow discrimination against marginalized groups directly. And some of these are very direct, kind of explicit and unmissable attacks on access to healthcare, like the rescission of ACA protections against discrimination on the basis of gender identity, both in healthcare and in education. There's immigration actions where now there is enforcement in sensitive locations, including in hospitals. There have been court actions that have upheld state bans on gender-affirming care. The conversion therapy case is pending. I hope, Craig, you're going to tell us about that. So some of these are really visible in healthcare systems, but some of them are not about health. And we need to care about those too, even if they are enacting or allowing discrimination in other areas of economic activity, it's still going to hit health outcomes. So this is a model that I built with a few co-authors, looking at how discriminatory laws that on their face have nothing to do with healthcare can actually produce health inequities or amplify health inequities among marginalized groups. So where you have a discriminatory law, we're illuminating, and people have talked about expressive functions of law for decades now, but we're really kind of putting this very explicitly on view, that people comply with the law most of the time, and so that's going to require or license particular behaviors. And when people comply with a discriminatory law, that changes the options available to marginalized groups and simultaneously changes the behaviors that are available to people in those marginalized groups. And those two effects will have health impacts. But then beyond that, and what might be even more powerful, is this expressive function. And that's where the law, by virtue of discriminating or by explicitly allowing discrimination, it expresses that it is okay to discriminate against members of particular groups. It is okay to treat people differently on whatever basis the law has chosen. So that actually is changing as people accommodate that new law in their thinking, in social norms, in their behavior. That really changes the acceptability of discriminating against a specific group kind of across all sectors, not just the place where the law is working, but that message that it's okay to discriminate against a marginalized group, or it's okay to treat them differently, or to refuse to give them extra consideration or whatever it might be, that changes the social norms in ways that pervade beyond the boundaries of the law itself. Similarly, people know that they're being targeted by law after law. And for some of these groups, particularly transgender individuals, these laws are coming kind of by the dozens, by the hundreds at the state level, in addition to the actions taken by the federal administration. So that experience directly of discrimination and marginalization from the law, as well as the messages that people are getting from the society around them, that has a health impact too. So even laws that don't focus on access to healthcare, laws that have nothing to do with healthcare, can nonetheless come out in the expression of health inequities. So we've had a lot of executive orders that have engaged in discriminatory attacks that aren't about healthcare or aren't confining themselves to healthcare, but nonetheless are going to activate these stigmatizing pathways and affect access to resources. And these have attacked kind of all diversity and inclusion efforts. They've attacked trans individuals. They've stepped up immigration enforcement. They have restructured foreign aid, as well as the types of organizations that are receiving foreign aid in ways that are hostile to a number of named marginalized or minority groups. There's also been agency actions. We're familiar with the NIH grant terminations, the curtailment of NIH-funded research and grants on diversity and health disparities. All of my collaborators have had at least one grant canceled. There's been the cancellation of really important decades-long data collection efforts by the federal government, such as the PRAMS, the postpartum health survey that the CDC has been doing for 2 decades. There's been the elimination of a continuing survey on drug use, proposals to eliminate the substance abuse and mental health and an arm of the CDC, and the elimination of a crisis line that many of us know about this from the Trevor Project, that it's a suicide hotline specifically focusing on LGBTQ populations, and that's been entirely ended. There have also been court actions, all of which have kind of amplified. And of course, these are not specific to the current administration. But I think that in popular consciousness, I'm not sure right now people see a lot of separation between this Supreme Court and this federal administration. And I do think there is some carryover between the way people experience the impacts of what each of these actors is doing. And so simultaneously, we've seen not only the end of affirmative action and the end of the federally protected right to abortion, but also further weakening of the Voting Rights Act, further weakening or the creation of exceptions to discrimination protections for LGBTQ populations. We've seen parents exercising the right to opt children out of inclusive content in public schools. We've seen further attacks on the types of providers that can participate in Medicaid and whether they can seek relief from the courts. And there's a lot of concern about whether these big kind of public precedents, court precedents that have protected marginalized populations are going to endure. So none of today's presentations are a happy story. This one is no different. But I think it's